Good morning, good afternoon, good evening. Welcome, everyone. We'll just give a minute or so for everyone to join. Thank you. Welcome, everyone. Good morning, good afternoon, good evening, and a special welcome, especially to those of you joining from far away or where it's very early in the morning or late in the evening. Thank you for joining today's EPI-WIN webinar on a framework for civil society organization engagement for public health emergencies, the launch. EPI-WIN, as those of you who are familiar with it know, stands for the WHO Information Network for Epidemics. And our main goal is to make information accessible, actionable for evidence-informed actions across health emergencies. Today, we will be sharing with you our new document for a framework for civil society organization engagement in health emergencies, and also getting the perspective both from a national government of Ministry of Health in Guatemala and from two CSOs from EBASE and ADO, as well as a regional and national perspective. And we will also hear from UHPR and how they are engaging CSOs. But most importantly, you'll also hear from the WHO Civil Society Commission, where Michelle Tulkamam will talk about what the Commission does. After that, we will have Q&As. Questions that you have will be answered by our panelists. But please do share your what you do, where you come from, and most importantly, if you have any perspectives that you would like to share, please do so on the chat. If you have questions, however, please put it in the Q&A box, not the chat, because that will make it easier for us to track. And with that, I request Dr. Kai von Harbo to welcome all of you and talk about the role of CSOs in community protection.
Thank you very much, Supriya, and good afternoon, everybody, and good morning and good evening for those that are joining from different time zones. I'm dialing in from Nairobi, Kenya, where we are conducting the first community protection training of trainers at the regional level. But for us, civil society roles in HEPA community protection is so important that I stepped out of this meeting that, by the way, also involves a lot of civil society representatives to open this meeting on behalf of our director, Dr. Stella Chungong, who's the director for health emergency preparedness at WHO headquarters, who is unfortunately not able to attend this meeting because of another important engagement she has. And I really want to welcome all of you, the civil society representatives that are here, the government counterparts, the WHO colleagues, and also the other many partners that we are working with in community protection and in this important area in particular. Today's session is really about how can we operationalize community protection by working systematically with civil society organizations. And as you all are aware, community protection is based on the recognition and the lesson learned from many health emergencies that communities are not passive recipients, they are active agents for protecting themselves and their communities during health emergencies. And civil society organizations are really central to make that happen. They are the most trusted voices, they are the sustainable partners at the community level, and they are the strong connections between the health system and the communities. We see it in every emergency that we are working in, how they can mobilize community health workers, how can they communicate risks, how they address rumors, how they keep health services accessible, in particular for the most vulnerable population, and maybe most important for us, how they translate our guidance documents into real operational action on the ground. And this is what this framework that you will hear more about today is really about. Another very important aspect for CSOs is their role in conflict-affected and hard-to-reach settings. And last week at the World Health Summit, we had a dedicated side event on this particular topic, on community protection in these important environments, and the role of civil society organizations in these settings was really strongly highlighted in this. And as you know, community protection is our framework to enable that, how to engage communities in decision-making and co-deliver interventions. And the CSO framework is now a key part of our community protection approach. And that's exactly what we'll hear more about today, a very practical step-by-step guide for member states to engage with civil society organizations across the emergency management cycle, with starting with the mapping of the local actors, then how to formalize CSO roles in the many different aspects of community protection, from surveillance to RCCE, to infodemic management, to community-based care and referral, etc. And then how to also create feedback channels. And what is really important is that for this to really function, we need everyone to contribute. We need CSOs to provide their capacities, but we also need government counterparts to share the responsibility, the information, to set up coordination mechanisms. And that's what we will hear today from the different partners and examples from the ground, how this can happen. So I really look forward to the webinar today, and then also how to work with you to operationalize this framework, and then how to learn from it and to improve it further. So back to you, Supriya, for facilitating the session.
Thank you very much, Kai, for that opening, where, as you mentioned, this is a very practical framework to highlight exactly how CSOs, we can work together with them to operationalize what needs to be done during emergencies. Before I talk about the framework, though, I'd like to hear from you. As you know, those who are familiar with it already, we always have a Slido. So it's slido.com. Slido.com, hashtag 1735009. Slido.com, hashtag 1735009. Does your country have mechanisms for civil society organization engagement for decision-making, planning, and implementation for health emergencies? Okay, we have... Okay. So, well, there do seem to be a number of countries with formal mechanism, some with informal, quite a few we're not sure yet. Okay, we'd love to hear from more of you. We have 46 people so far. A few more would be nice. Okay, I will stop sharing the screen in the interest of time, but I will leave this open, so please do put your feedback in at slido.com, hashtag 1735009. And if you have perspectives on civil society that you would like to share, please do so on the chat as well. And with that, let me go to Can you see my screen? Right. So this framework, actually, the story began in COVID. My colleague Nelly Corteglu worked with to engage directly engage civil societies, 54 grassroots civil society organizations working with WHO regions and countries. It reached 40 countries and 80 million people. And you'll hear some of that. This is a document where, you know, what was done is documented, and I've given the link as well. We will share the presentation later. But what we do know is civil societies work in emergencies and have been working in emergencies. Where there was a gap was in the systematic inclusion of CSOs. It's tended to be more an ad hoc reaction or something that's more response related, but there seems to be a mechanism lacking in many places for systematically mapping CSOs, their role, including them not just as participants, but as equal partners in decision-making, planning, implementation, and accountability. And so that's where this document started, and it aims at enhancing community-centered decision-making, planning, and implementation for a whole of a society approach to health. What it does is has 10 very practical steps to support a harmonized multi-stakeholder approach to strengthening community resilience. And it's made, you know, it started off actually, to be honest, to support WHO staff who were trying to, the country level and the regional level, who were trying to engage. So it was clear that we needed to engage civil society organizations more. And so it started with that. So it's expanded to WHO at all the three levels, national, regional, and global, to all our partners, as well as to national counterparts and the ministries of health. What needs to be done? What are some of the things that could be considered while engaging CSOs? And this is very much aligned with WHO localization strategy, which, as you know, empowers local actors to take ownership of health emergency management. So what is this framework about? It's about CSOs taking ownership and working for ministries of health and partners and WHO working with CSOs step by step to work with communities and strengthen community resilience. Well, the key point is, first of all, is mapping CSOs, because often they are the first to respond in an emergency. They work in a wide range of areas, starting from health services to advocacy, to maternal and child health, to, you know, community-based surveillance. And they're not all health-related issues. It expands across the board. So who is doing what, where, and how can we work together? What is each organization's strength, and how can we work on those strengths to have a more synergized approach? So that takes us to the second step, defining roles and responsibilities. Then we move to establishing communication, feedback, information sharing channels, what CSOs hear from communities, what they can represent communities to the government, as well as the other way around. They can inform communities about the thinking from governments, national governments and partners. Then working together for joint needs assessment for preparedness and response, ensuring inclusivity in those needs assessments. But the CSO planning and engagement needs to be in alignment with national and local strategies. Also, the next step is ensuring coordination and reporting mechanisms, collecting data. Step 8 is enhancing and strengthening capacities and peer exchange and knowledge. Of course, advocacy and resource mobilization, again, a more synchronized approach will probably be stronger. And finally, piloting new approaches for good practice dissemination and moving ahead. This was conceptualized very much as a living document. It's meant to evolve. So today is really the first step, and we share this with you. We'd love feedback, and this can be evolved and strengthened as we implement it. It's also, although we have step 1 to 10, it doesn't mean it has to be one after the other. They can be all used in similar steps. I won't take up too much of your time here, but I wanted to focus on the first step, which is mapping CSOs, because that's critical. Excuse me. Who are the key stakeholders to support mapping? Who are we trying to reach? What are we trying to reach them for? What are the laws and regulations? Excuse me. Excuse me, it's the weather. But then we compile a list of CSOs, categorize them, create a database, validate the data, assess CSO capacities and resources, define priorities, and match needs. Select CSOs for specific actions, collaborate and coordinate, and collect and disseminate best practices. A key point here for partners, and this is an issue, thank you, is making sure that we also conduct due diligence and background checks to ensure that the organization's goals and aims are aligned. For WHO, this involves a framework of agreement with non-state actors, as they also need to agree on WHO policies and prevention. So it's important when working with WHO that the CSO is aware of its duty to report any conflict with the ethics and values stated. Then feedback mechanisms are also very important. So it could be through regular consultations and stakeholder meetings, or it could be through digital platforms. Inclusive planning, and I hope we will hear more about that from Ms. Virginia Herzig in their experience in Guatemala. And the importance of collecting data. These are just a very brief overview of what the framework is. You have the link in the chat. Please do look it up, and we look forward to hearing from you. Thank you. Okay. So now I would like to move on to our, that's an overview of the framework, but to really what the action was and how we can implement it. So over to our panelists who I'd like to introduce here. We have Ms. Virginia Herzig, who's the head of preparedness at the Ministry of Health in Guatemala. We then have Patrick Okwin, who's a research lead for eBase in Cameroon, but eBase also works across many countries in Africa. We have Wafa Magadi, who's with ABO in working on women and children in well, Yemen, but also a co-chair of the CSO Commission. And finally, we have Ruben Samuel, who's the program area manager for WHO CRO, but has worked at both the regional and national levels. Before we go to the, I apologize, before we go to the panelists though, I'd like to invite Michelle Tulkanam to introduce the Civil Society Commission in WHO.
Thanks so much, Supriya. I'll just briefly talk about the WHO Civil Society Commission and its role. The WHO Civil Society Commission was started in 2023 at the request of civil society for more structured and meaningful engagement with WHO, and gratefully DG agreed and the CSO Commission was established. Over the past 2 years, it's grown to a global network of over 540 civil society organizations working across health and development. The goal of the Civil Society Commission is to strengthen collaboration with civil society and ensure that their voices shape global health policies, decisions, and actions, because we know that WHO's work needs to be reflective of people's needs on the ground. So what does the Commission do? We regularly convene information and dialogue sessions to share WHO's policies and guidance, and also directly hear from civil society organizations. And these sessions help CSOs take action locally or provide feedback on the ground or share with us insights that we can reflect in our work. We know that, as Kai mentioned, CSOs are not just passive recipients, but actually active agents of change. And so we definitely want to hear from them, reflect their experience, and work with them in shaping our policies and decisions. And we know that any outcome involving CSOs will be far more richer to ensure health for all. With regards to this framework, the Civil Society Commission has been really active in integrating civil society's voices into this framework so that it is tailored to what communities need on the ground. And we look forward to supporting its implementation. Over to you, Supriya.
Thank you very much, Michelle. And with that, I'd like to invite the panelists. The first person I'd like to invite to speak is Miss Virginia Herzig, who's head of preparedness at the Ministry of Health, Guatemala. Guatemala has been active in engaging CSOs for health emergencies. So how has Guatemala engaged CSOs as partners? What are some of the things you've done, and what are the key benefits and challenges? I'd like to also announce that her presentation will be in Spanish, but interpretation is available if you go to the interpretation booth at the bottom of the screen, which is the globe, and then you can choose the language you like. Can you hear?
We can't hear anything.
Miss Virginia, we can't hear you. If you could just check your mic.
¿Me escuchan ahora?
Yes, we can hear you now. Ok, perfecto.
Very good. Thank you. I am Virginia Herzig from the Department for Public Health and Social Assistance. And I'd like to share with you the experiences. The interpreters would like to say the sound is very, very poor. The interpreters would like to say the sound is not sufficient for interpretation.
I'm sorry to
The
interrupt.
interpreters could read the text we have been supplied from, but we won't be interpreting as such.
My apologies for interrupting, Miss Virginia. Could you put your mic nearer? The interpreters are having difficulty interpreting.
Can you hear me better now? Slightly.
Interpreters, is that better?
It's a little better. The speaker says she's getting echo and can hear herself. Speaker is going to try. As I said, our specific law for health matters ratifies the right to health and aims to protect people. The interpreters apologize. The sound is too fluctuating and we are missing too many words to be able to interpret.
Interpreters, we can't hear anything.
Madam Chair, we apologize. The sound quality is not sufficient. The sound quality is meaning that we're missing half the words. And it doesn't make it possible for us to interpret correctly. The speaker is saying she is hearing herself and she says she can hear herself clearly, but the sound keeps fluctuating from one word to the next.
We can hear the speaker, but not the interpretation. Interpreters.
This is the English booth interpreters. Can you hear me? Within the framework of this program, we set up a board to build capacity for the inclusion of persons with disabilities in the management of health risks. We included representatives of civil society with visual disabilities so that we could try and build a program. This board is made up under a government act, and this board continues to work with different bodies from the health sector, civil protection, NGOs, and representatives of disability groups and civil society. We set it up around 5 axes for work, which aim to find mechanisms and spaces for participation by civil society in capacity building processes for the sector so that we could guarantee inclusion of persons with disabilities in the planning. We also established a strategic plan over 5 years, and this was presented and approved by the Roundtable Coalition for Persons with Disabilities so that we could ensure that the elements included in the plan would take into account their needs. Another part of this initiative has included the application of Ingrid H program in hospitals in our national network. Currently, 6 of the 48 hospitals have been evaluated with the use of this tool within the initiative of safe, resilient, and inclusive hospitals that we as a country have adopted. Unfortunately, the theme of including persons with disabilities has not been a subject that was driven with a great deal of force within the health sector. The majority of our health services have been qualified as not being inclusive, but this tool looks at those action plans that do not involve the financial investment to ensure the suitable conditions for persons with disabilities. But through this significant activity, what we're doing is ensuring that persons with disabilities who work in hospitals, who are patients, or who are regularly visiting our facilities, that they will be taken into account in the planning of risk management activities in the case of emergencies or disasters. Currently, we are finalizing the program of setting up a diploma for the integration of persons with disabilities with the significant and important participation of representatives of civil society so that we can ensure that all elements that are necessary be taken into account so that we can raise awareness and take into account the importance of the subject. We are most grateful for all the work that we've received from Dr. Ugarte, Dr. Alex Camacho, Dr. Gispara, and all of the PAHO team who have helped us with capacity building in the country and have opened our eyes to the importance of the participation by civil society in such important processes. Thank you. The interpreter would like to point out that once the speaker held her microphone in front of her mouth, it was better. Thank you.
Thank you very much, Ms. Virginia, for that presentation talking about the important points that Guatemala did to engage CSOs. For those of you who had problems, there is interpretation. Initially, we had a few issues, but it was working fine. If you go to the globe at the bottom and press the language you like, we have French and Spanish interpretation today. Thank you. Thank you very much. And with that, we'd like to go to the CSO perspective. And I'd like to invite Dr. Patrick Okwin, who's the research team lead for EBASE in Cameroon. EBASE and other CSOs work in many countries in health emergencies in a number of areas, from research to community protection. Patrick, in your opinion, what has worked well in CSO engagement with WHO, with partners and national governments as part of a whole of society approach in health emergencies? And how can we better engage with CSOs more systematically? Thank you, Patrick.
First, thank you very much, Supriya, for inviting me to this very important session, and especially to share our perspective from EBASE in how we've engaged with WHO, and especially more so WHO resources and governments, not just during the COVID, but also with other emergencies that probably happen and are not at global level, that are largely ignored. For example, cholera outbreaks, conflicts, monkeypox. I mean, monkeypox came earlier, and then when it was going global, the whole world responded, and then we benefited from the fact that the whole world was responding. So at EBASE, we've learned that civil society is not just a messenger, it's the muscle and the memory of community resilience. And our engagements with WHO resources and governments, especially during the COVID period and other emergencies which I mentioned, has demonstrated that when civil societies are enabled or empowered or engaged, the response becomes faster, more trusted, and more equitable. And I'll highlight this in a number of examples. So first, if I start with the COVID-19 experience and evidence and the community protection initiative, which we had, where we built on resources that were coming from WHO and within a project that we were conducting at that time called RegMaps, COVID RegMaps. And with the ministries in Cameroon, in Nigeria, and in Chad, with decentralized structures as well, to bridge scientific evidence and community realities. So what worked well? We believe we enabled community groups, including faith-based organizations, women's organizations, especially in the northern parts of Cameroon, by translating WHO guidance into simple community stories and radio dramas. We also empowered them with evidence from rapid reviews. RegMaps actually literally stood for rapid recommendations and mapping of rapid recommendations. And this focused on the importance of using masks, being careful to identify misinformation, and also exploring vaccination safety. Through certain coordination mechanisms, and this is the beautiful thing sometimes with WHO coordination mechanisms like this framework, it becomes available. It's open source, public good. So it means that every civil society can tap into it. And because we are tapping from a document that we've been able to work together on with the WHO, it creates more trust with both governments, with practitioners, but also with people. And we are able to use these channels to deliver life-saving information where formal systems could not really reach. So this mirrors steps 3 and step 7 from the WHO framework. And I'm trying to mirror this because in essence, we are looking retrospective and it can really contribute to validate some of what WHO is already doing. Now, the second example is in the transfer model and storytelling that we have used at eBay. So with the transfer model, technically is we find ourselves in a crisis, but there is no local evidence, but there is evidence from a different context. And we want to ask ourselves, how can we transfer this to our context and then put this into story that we can communicate with communities? And that is where we come up with co-creating with community members, combining oral storytelling, even at certain instances, bringing in artificial intelligence. Now, it's important to think about why some of these partnerships were so successful. I think part of it was shared accountability as well with governments, with local partners, and moving forward. And I think my participation as well in one of the WHO sessions, which was in Istanbul, was very helpful in the process. So there is also the aspect of it leaves an open door for us to bring in local philosophies, local principles, and apply to the whole situation. Now, I think moving forward to conclude on what I want to share is to really think about how to engage civil society more systematically. I think one thing I was happy from Kai's talk and I think from two talks that came from WHO is the fact that this document is still open for us to bring in contributions. So how can we map beyond formal civil society organization? How can we co-develop capacities and share across the civil society organizations? How can we institutionalize this participation? How can we invest in local data ecosystems? How can we sustain engagement beyond crisis in times of peace, in quotes? So in short, what worked was trust built on co-creation. And if we embed this trust and systematic inclusion, we'll be able to contribute even more effectively and more practically in the framework that is being developed. And I would want to conclude by saying that at eBase, we are also available to come in to have more serious discussions on how we can bring in evidence and technology, co-creation, localization, and trust, and really formalize global partnerships around this. Thank you very much.
Thank you very much, Patrick. That was very succinct, but very clear that the way you've worked, through storytelling, involving communities on one hand, taking the evidence to communities in their means, and secondly, using storytelling and co-creating with communities. Thank you also for sharing how we can move forward together. And that is something that we will definitely take note of. This, we hope, is just the beginning, and we will continue in this process. So thank you. The next question is for another CSO perspective, for Dr. Wafa Al-Mataki. She works for UP, which works for women and children. So and also in Yemen, which has had conflicts. So women and children are amongst the most vulnerable in an emergency. How do CSOs work with regular channels to reach them, especially in your context, when there's conflict? And what are the two biggest challenges, and how can we improve them and strengthen this role? So that question is to Dr. Wafa Al-Maghdagi.
Thank you. Thank you for being with you here today. And thank you for the question. And it's very interesting to hear also. I gonna talk about today from our perspective. And you know that Yemen is we are suffering from the conflict now for more than 10 years. And regarding indeed for the women and children, we could say that they are the mainly affected in emergency, not only because of the constrained access to the basic services, but also they are having a problem related to protection risk, social vulnerability that they in this crisis. From our experience as ABS Development Organization, ADO, in Yemen, while we are a women-led organization and also CSOs operating for 30 years till now, we play as a vital bridging role between the affected community and formal humanitarian and government structure. We do through community-based network. So in our intervention, we do women-led committee. We work through local health volunteer, mother-to-mother groups, so that they're helping us to identify and doing the referral mechanism for the most vulnerable access and cases to the regular service channel, which will include health facilities, protection unit, and social welfare program. This is depending also on the refer mechanism and how they are referred. We also work closely with local authorities, with the UNI NGOs and partners who are operating together. So we are working to integrate and complement each others, to integrate this community voices into planning and response process, ensuring the assistance in both gender and age responsive, which we also speak here that about we have to ensure the accountability. According to that, we have two main challenges that mostly we are facing. The first challenges is the access and operational constraint. In Yemen, as a conflict affected or a hard to reach area in some area, there is a limited mobility. There is also security restriction that mostly prevent timely delivery of assistance for women and children. How we address this, and we are trying to address it, we need to build a stronger coordination and flexible access framework that empower local CSO how to operate safely and sustainable, because we know that CSO, they are mostly the first and the last responsible. Secondly, or the second challenges that I want also to address today is the resource and capacity gap. Funding for local and mainly women-led organizations remains small and short-term, and especially in Yemen and after COVID and reduce of fund, this is also proven reduce and affecting our operations. So that effectiveness in community outreach, trust building is very important. How to overcome this gap? Mostly we promote direct financing as much as we can. We do integrated programming, long-term partnerships, technical support sometimes for national CSOs to sustain community-driven system. We are also now trying to encourage the private sector rules through nexus rules, so that as another source of financing, so that we try to continue the functioning even beyond the emergency. So in summary, because I have a limited time, we want to say that reaching to women and children effectively require localization, trust, sustainable collaboration, partnerships between CSO, formal humanitarian actors, ensuring that no one is left behind, even in the hardest conditions. Thank you.
Thank you very much, Dr. Wafa, for that summary, especially for the challenges, the very difficult operational challenges that you face and how you're overcoming that. My apologies to those who seem to be having sound issues. We have a suggestion from our AV technician that when you're not using your interpretation channel, choose the original audio to avoid echo. And my apologies for those of you who have had sound issues. There seem to be different opinions. Some are fine and others are not. I would now like to invite Ruben Samuel, who's been working in many country offices and is now the program area manager of the Southeast WHO Southeast Asia regional office, leading amongst others community protection. and he's been working with CSOs in a number of fields. So, Ruben, you have worked with CSO partners at the country level as well as the regional level during health emergencies. Could you share with us how CSOs as partners have brought value in the whole of society approach to health emergencies? And from the WHO perspective, particularly, what were some of the challenges as well? Over to you.
Thank you, Supriya. I hope you can hear me well. Thanks for the opportunity and the privilege.
Yeah, we can hear you fine, Ruben.
Thank you very much. So, we have been engaged with the CSOs on a variety of issues, not necessarily limited to emergency risk management, also engaged at the WHO country office level and also at the regional level in developmental issues or health systems strengthening issues also. And what we have actually found is that CSOs bring a lot of values, specifically in certain areas. One is that they are the connect and they are the people who are able to channel the social capital that is available at the community level for bringing together a variety of actors at the community level, be they small CBOs or the local administrations or individual volunteers and groups together to work on a common platform. And so they are basically the social capital aggregators at the community level. The second is basically they are very good at working in niche areas, especially in the last mile connectivity, is in areas which are hard to reach, where usual government services, health services are not reachable, and also certain vulnerable communities where because of various issues, especially related to stigma, either they are not cared for or they don't have access or they themselves don't seek care. So that is another area where we have good response and a good collaboration with civil society organizations. The third is whenever we want to try out new things, when the risk of failure will not be will not be tolerated as much by government entities when we want to innovate, when we want to improvise, and we want to try out new things. Mostly we find that CSOs are the ones who are willing to take the risk and trying to kind of innovate and try new things and new interventions. And if they are successful and the proof of concept is demonstrated, then they are also the people who are very good at, along with co-creators and the society in general, able to kind of advocate for scaling up of such interventions so that they become part and parcel of the routine healthcare or routine intervention. So in some of these areas, we have used CSOs and we have worked with CSOs and we have co-partnered and co-created with CSOs, not only in response, but also in preparedness and in emergency risk reduction per se. So whenever we need a solid advocacy emanating from the ground level, then also CSOs are the most important sources of such advocacy, and they are able to speak with not only the community, but also especially the local authorities, and then from the local authorities build up the advocacy up to the national level through the provinces and the states. So there are these variety of ways in which CSOs are very helpful and have been co-partners in our work. As I mentioned, not only in the area of risk reduction for emergencies, but also in health system strengthening. And lastly, civil society organizations are also very good in working in niche areas. For instance, for an example, in India, we have most of the health workforce and the health infrastructure, etc. Since independence, since largely India was a largely rural country with most of the population in the rural areas, the rural health infrastructure was much well developed than the urban health infrastructure, especially among the urban poor. And in such settings, it is the CSOs who actually come to the fore in working with governments and working with international and local developmental partners to move things ahead so that systems even can be experimented and set up. So these are some of the good things that I have actually observed experientially working with the CSOs. Now, coming to the challenges, I think the challenges are twofold. One is especially as some of my previous speakers have actually alluded to, if a particular government, be it at the local level or at the provincial or intermediate or even at the national level, has a very systematic way in which they are able to engage with the CSO, and the CSOs are welcome to be part and parcel of the developmental uh, part and parcel of the developmental agenda, then it is much easier for intergovernmental organizations such as ourselves, WHO, to much easily engage with the civil society partners. Many times, direct engagement of WHO with civil society partners is not that easy, especially because largely we are supposed to work with governments per se, and then only with the leave of government able to work with civil society organizations. Now that has kind of changed during COVID, where we tried to work directly with civil society organizations. And we worked with a variety of organizations, especially in the area that I was working in with Federation of Disabled People's Organizations, a large NGO which was actually dealing with mental health issues and working with people suffering from mental health issues, and NGOs and CSOs, other CSOs working with mental health issues. We also worked with the Red Cross movement, and thereby were able to work at the community level in disease surveillance, especially even with mortality surveillance, etc., when it comes to COVID-19, and also working with the quarantine centers, working with migrant workers, and a variety of such issues. I think in all these issues, sorry, somebody is on, so I'm getting an echo. If we are able to kind of work with such niche organizations, and also CSOs which are catering to specific vulnerable groups and specific interest groups, we were able to work together well. But if we are able to get our work done with the catalysis and with the support of government, it is easy for intergovernmental organizations. But directly working with CSOs becomes important, because then we might be questioned, or there is not sufficient resources, and WHO does not also have operational resources in the field, such as some other organizations like UNICEF, etc. And thereby it is much better to kind of work with a multiplicity of intergovernmental organizations, especially with those organizations which have a kind of established network and established way of working with CSOs. And these are some of the mechanisms that we used. So WHO provided the technical know-how, the capacity building, the technical tools, etc., whereas we worked with UNICEF, and UNICEF engaged with the CSOs directly, and then did the operational elements and the monitoring and evaluation, etc. So that is something that really worked well in our experience. And lastly, our FENSA clearance and the way in which we have very limited ways in which we can actually contract CSOs also make it actually very cumbersome and very prolonged before we can actually engage with CSOs. So the framework, and also the mapping, the stakeholders analysis, etc., and also in communicating with and identifying the prioritization roles and responsibilities, and engaging with CSOs beforehand, and then contracting CSOs in peacetime will also help in really moving forward very fast during emergencies, because our experience has been, while we start looking for engaging with and working with CSOs, when the emergency is already upon us, then we lose a lot of time. Whereas what would actually really help is to have a framework which actually helps us to identify, map, and then engage and communicate, and also contract in a formal manner with CSOs whom we are interested in working with during peacetime, during preparedness. That will actually much better work for us when it comes to emergencies, given that our contracting modalities take a long time. So let me stop there. Thank you very much.
不是咱们喽，为什么没见着？Okay, can you hear me, colleagues? Okay, should I start, Supriya? Okay. Then, yeah, I know it's relatively late. Just my name is Junxing. I'm the head of the UHPR Secretariat. UHPR represents Universal Health and Preparedness Review, which is a initiative launched by the DG like 4.5 years ago, in order to respond to lessons learned from COVID. So I know I have 5 minutes. I mean, originally it should be Ludi, who is my unit head, who is supposed to do this. Oh, Ludi's talking. Sorry. 他把咱们已经那个挡住了。Hello? Oh yeah, okay, sorry. I thought Ludi is sorry about the communication. My name is Junxing. I'm happy to do the presentation on behalf of Ludi, who is my unit head. I'm the head of the UHPR Secretariat. So without further ado, next slide, please. Thank you. It's relatively short because I have 5 minutes to present to you the CSO component of the UHPR. So it includes an overview of the UHPR in a nutshell, the CSO engagement with the UHPR. We also give you a country case study in Sierra Leone, which has done a UHPR in May earlier this year, and of course the next steps. Next slide, please. Yeah, a bit of background. I won't be long. As I said, UHPR is largely initiated in response to lessons learned from COVID. In COVID, we did observe the challenges in terms of leadership, in the fragmentation, in terms of coordination and strategic coordination among the different sectors in response strategies. Of course, relatively, senior officials were engaged, but actually there many times in terms of the coordination among different sectors, there still need to be a high-level mechanism to facilitate the response in that regard. Next slide, please. In a nutshell, UHPR, there are 4 phases. First phase is to prepare for the UHPR process, meaning the countries will actually receive guidance and information from the Secretariat in order to lead up to the high-level mission. Of course, there's a lot of work to be done. Normally, this process takes around 6 months to 3 to 6 months. The second phase is the national review, which is actually the peak of the high-level mission.
which is the engagement with the national leadership. Overall, we have altogether 8 countries in already engaged in this process, and many times the delegation from WHO get to meet with the heads of states, including the prime ministers and presidents. So this is normally a 2 to 3 days high-level mission, mainly involving high-level talks, bilateral meetings, and so on, with the senior leadership, with relevant ministries to sort of highlight what has been identified in the national UHPR report as a national priority in terms of health emergency preparedness. The third phase is what we call the global peer review phase, or the policy dialogue phase. We already have one GPR so far. What the process does is to review the national UHPR reports. And I mean, of course, the panel includes representatives from member states, and the national reports from the UHPR countries who have done the UHPR will be reviewed by all member states. And of course, in this phase, CSO will be heavily engaged. I will actually elaborate on that in the next few slides. And of course, there will be the national follow-up phase, which actually, based on the recommendations from the global peer review, the countries will need to develop plans, take actions to implement the recommendations. And of course, the next cycle, we're saying that normally takes around 5 years for the country to apply for another UHPR. Well, this slide talk about the why, I mean, how we have been engaging CSOs. Of course, we realized right from the beginning that the importance of the CSO engagement, not only to improve transparency, but as well at the country level to sort of enhance the accountability, and of course enhance the collaboration among the government sector as well as the CSO sector, so that to sort of increase the effectiveness in terms of response. There are actually activities that are conducted by CSOs in the country, and also of course many times in the grassroots levels, which cannot be replaced by government activities. So, of course, as I said, the CSO involvement talks about all the 3 phases. One thing I want to highlight is that in the design phase of the UHPR, we have established a technical advisory group, and which actually provides guidance and recommendations to the UHPR Secretariat in designing the functioning of the UHPR. Under that tag, we have a subgroup solely on CSO, so which actually we receive a lot of guidance or expertise comments from that group. We actually had very famous kind of CSO experts across the world who advise us on the different phases, how and of course why we should involve CSO, and how we can actually involve them in the different phases, including the national phase, where, as I said, we normally have a government, of course, plus the CSO kind of discussions to hear their views, which actually the government will otherwise not be able to hear. And also, of course, as I said, the global peer review phase, the UHPR reports will actually be circulated among the CSO networks globally for their feedback, and the questions will actually be feedback to the countries concerned, so that they actually can provide their answers upon the time of the global peer review. And of course, the follow-up phase, which is critically important as well, because we really need the CSOs to be fully engaged in order to implement the recommendations, because many times there are things that need to do in order to complement what the government is actually doing. We all definitely need their full commitment and support in order to implement the recommendations and so on. Next slide, please. Just give you a very concrete example. We have conducted country case studies, of course, across 5 countries so far. One of them is Sierra Leone, which actually did their UHPR national phase in May 2023. And as I said, through the national phase, of course, we of course, I mean, let me let me start from the beginning. Even during the preparation phase, we actually provide some guidance in terms of we develop the CSO guidance and to really help the country how they can engage CSO at the national level and also, of course, at the subnational levels in order for them to in the process of writing up the national UHPR report to make sure that the CSO, the voices from CSOs from different levels are heard, and also, of course, their views are taken care of in the national report. And of course, this is actually quoting from the country case studies. Actually, they highlighted a lot of outcomes or benefits that they have gained. They have gained a lot of benefits in terms of course, I mean, the government, I mean, actually were fully supported by the CSOs. Of course, there are things that they raised during the process, which were actually help the government to improve how they can better involve them going forward. And of course, there are also things that they highlighted. For example, the CSOs did help them to ensure that their involvement in terms of improving strategies to prevent future epidemics and how they can work together to actually improve the process of response processes to ensure that there's unbiased and efficient interventions. Of course, they also highlighted the fact that they have improved access and or equity in underserved populations, especially those suffering from mental health issues. This is just to give you an example of how, and I mean, how we can, this process can benefit a lot from the CSO engagement. Next slide, please. Very quickly on the next steps, we will continue exploring the best ways to engage CSO. Of course, we have done a lot of pilots in 8 countries so far, and we have learned a lot. And we have been updating our CSO guidance going forward. Of course, there will be more lessons to be learned, taking into account the country context. Going forward, we actually have been developing a guide on CSO engagement, communities, and also people in the UHPR process. The guide is actually is a working a work in progress, and so we really appreciate all the inputs from all our colleagues from country offices, from regional offices, as well as from here at the headquarters teams who have provided a lot of very important and very insightful comments to help us to sharpen the CSO engagement guide. And of course, using the guide, we're going to ensure that the CSO guide will be fully implemented. Or I mean, we hope that the guide can really help countries in their process of engaging the CSOs. We, of course, will be looking forward to further collaboration with the WHO teams and other partners, particularly our CSO kind of colleagues at the national, regional, and country levels, to make sure that we actually will we make sure that CSO continue to play an important role in the involvement of the UHPR, so that every citizen, every population can benefit from this process. Next slide, please. Yeah, this is just pictures are full of, I mean, so, just to give you a sense of the level of engagement we are in the countries. As you can see, you may recognize some of the major figures here in WHO, as well as some presidents and prime ministers, and including the president of CAR, president of Tanzania, prime minister of Tanzania, the deputy prime minister of Thailand, and so on. So, in a nutshell, we're actually trying to bring emergency preparedness to the highest level, so that we to guarantee that we have the much needed political commitment, as well as sustainable financing, to make sure that the emergency preparedness is sufficiently financed, so that we can be prepared for the next pandemic. Next slide, please. Yeah, I wish to thank you very much for your attention, and please feel free to contact us if you need any further information. And again, we look forward to collaborating with you going forward. Thank you.
Thank you so much, Supriya, and thank you to our panelists and speakers. That was really a lot of good experiences and new ideas and innovations coming from the different countries and also from the new frameworks. We actually received a lot of questions in the Q&A box, so we thank you for your active participation. Due to limited time, we probably have around 5 to 7 minutes for this Q&A. So let me ask first our colleague Patrick from eBase in Cameroon. He was giving us experiences about storytelling, about joint activities, assessments from their group. So given the different activities, how can CSOs ensure quality of your response or your activities? And how could you also effectively coordinate with government and with international partners? Over to you, Patrick.
Thank you very much, Deroy. And I would like to start by saying that having um, a working document like the framework is probably the first step towards ensuring that we can facilitate that to happen. Because I think the beautiful thing with WHO and WHO resources is that it comes with trust. And of course, I understand that this trust may not be 100% all the time because there are lots of other complexities on the field. But that is exactly how we use these resources from WHO. Now, in co-creating or in contributing to whatever comes from WHO, it further adds trust and improves quality as well. So it brings along quality and trust. It's a lot of rigor that goes into most of the work that's done already from WHO. So when we partner this with government and our experience, I think that is part of what makes the successful ingredients. And in the case of storytelling, what makes it very good is the fact that oftentimes we do not have to conduct the systematic reviews altogether or develop all the recommendations altogether because these are available likely in a document that's already coming from government or from WHO, or most of the time from WHO and partners like governments. And these have already sorry, okay, can you hear me better now?
Yes, it's better if you're closer to the speaker microphone.
Okay, to the speaker. Okay.
Yes, that's
All right.
better.
So these are the ingredients that we believe that can add value. And in the example of storytelling, which we have done in COVID within the red maps, this was work that we did with WHO and McMaster University. And this was able to provide us with good evidence on certain aspects of COVID management or prevention that was being distorted by misinformation from social media. So this is the kind of thing that we look forward to ensuring that there is good quality. Thank you, sir.
Thank you so much, Patrick. And thank you for emphasizing also the importance of framework and agreements between CSOs so that you can effectively work closer with government and with partners. And you emphasize also building trust and the use of existing resources and global guidance and references. So thank you so much for providing this quick advice. Let me ask our colleague Wafa from ADO, Wafa. And this is a question from Alvin Lontum. And this is about because you were presenting earlier about your CSO focused on response for women and children in emergency situations. So what do you think is the role of community health workers, our colleagues, our co-workers in communities or those with indigenous knowledge? How can they strengthen also our work? Wafa? Wafa, you can unmute. Yeah, she's not responding. Sorry for that. So let me move on to Virginia. our colleague from Guatemala Ministry of Health, and she will be responding in Spanish, so just check out the English interpretation. So this question for Virginia is from Lydia Asuniti. And Virginia earlier was speaking about the Ingrid H program and how they have engaged persons with disabilities. So the question is, how do you ensure continuous engagement with CSOs or like persons with disabilities for the Ingrid H program and other programs? And in your experience, what have been the results of this collaboration? What policy developments, changes, actions, or even joint activities that have resulted from this partnership? Over to you, Virginia.
Muchas gracias. Espero que tengamos mejor audio. Bueno, garantizamos la participación de las personas con discapacidad a través del acuerdo ministerial. En este acuerdo se establece quiénes integran la mesa de fortalecimiento y dentro de esas participaciones están representantes de las organizaciones de sociedad civil de personas con discapacidad. Adicionalmente, en el país contamos con un consejo de personas con discapacidad que vela constantemente por la inclusión de las personas con discapacidad en todos los espacios posibles para la toma de decisiones de política pública que beneficien y garanticen el acceso a los servicios de forma inclusiva para las personas con discapacidad. Parte de los resultados que tenemos tangiblemente es la participación de organizaciones de la sociedad civil en el diplomado que hemos montado como Ministerio de Salud para la iniciativa de hospitales seguros, resilientes e inclusivos. Y que dentro de sus proyectos han incluido este componente de Ingrid H para fortalecer los servicios de salud a nivel local basados en los resultados de las evaluaciones. En cuanto a política pública ya establecida, también se han identificado algunas necesidades de reforma que se han ido trabajando con la Comisión de la Discapacidad del Congreso de la República. Gracias.
Thank you so much, Virginia, and thanks for sharing actual and concrete and operational actions actually that was done in Guatemala, including the importance of having agreements with government and also with other CSOs. I think in the interest of time, we shall have to close this, but we see a lot of questions and many references and global guidance have also been shared in the chat. And there was also a comment earlier a recommendation earlier to provide a report from this EPI-WIN webinar. So thank you so much, colleagues, and I give back to Supriya to close the webinar. Over to you, Supriya.